Thank you. So after that exhaustive talk from Neeraj, so let me come to my lecture on approach to peripheral neuropathy and lived on localization. So I have nothing to disclose. So what I planned in the outline is first to talk about a basic localization, how to reach a peripheral nerve system, then go to the history and examination, then go to the pattern recognition, and just brief overview of investigations. So I'm not touching the individual diseases because it's an approach disease and they will be each covered in the future sessions and in the coming weeks. Let's do an overview on approach to peripheral neuropathy. In any localization in neurologists, we need to identify whether it is an upper motor neuron versus lower motor neuron. If it is a lower motor neuron, especially we're dealing with the peripheral neuropathic diseases, whether it is a coexistent upper motor neuron in disease is present or not. In the lower motor neuron, if it is in the lower motor neuron, if it's the anterior horn cell, or the later on, if the sensory part is ordered, the dorsal root ganglia and the sensory part, the root, plexus, nerve, neuromuscular junction, and muscle. So, what's the difference between a lower motor neuron and a peripheral nerve system? Of course, sensory part is involved in the peripheral nerve system. Other than that, when you talk about lower motor neuron, we start with the anterior horn cell, the part which is there inside the spinal cord. In the peripheral nerve system, we talk about something which is outside the spinal cord, preferably outside the dura. That's when the peripheral nerve system starts. So UMN, which we all know is a cell body, lies within the motor cortex in the brainstem or from the corticobulbar and the corticospinal tracts, and they terminate in the either in the anterior horn cells, the spinal cord, or the cranial nuclei. From there, until that point is the upper motor neuron. From there, from the cranial nuclei onwards, or the anterior horn cell onwards, the lower motor neuron system starts. It mainly consists of the anterior horn cell, the spinal cord, and the motor nuclei of the brainstems. And the axons comprise the anterior spinal roots, spinal nerves, and up to the skeletal muscle. So LMN is the final common pathway. Rest of the anatomy, I think Neeraj has covered pretty well. So how to go about with the history in a peripheral nervous system? Obviously, you take about the negative motor symptom, positive motor symptoms, positive sensory symptom, and the negative sensory symptoms. The negative motor symptoms, the weakness, fatigue, wasting, atrophy, walking difficulty, gait difficulties. Positive motor symptoms like cramps, fasciculations, myokemia, or tremor, neuropathic tremor that you see. Then positive sensory symptoms, all the paresthesias, allodynias, hyperalgesia, pain. The negative sensory symptoms like numbness, hyperesthesia, sensory ataxia, or even difficulty in differentiating hot and cold. So forget about the numbers, but at least we can know that presence of a spontaneously reported paresthesia is helpful in differentiating acquired from an inherited polyneuropathy. When patients doesn't have much sensory symptoms, but on examination has more significant sensory signs, that's one clue towards an inherited neuropathy. Acquired neuropathies have more of presenting sensory symptoms. And weakness may not be appreciated around at least 50 to 80% of nerve fibers are lost. So you get a significant nerve, not even lost, are affected, you get a weakness. So during history taking, sensory symptoms often overshadow the motor symptoms. So the exclusive, because of maybe exclusive sensitivity to sensory systems, the earlier involvement of the sensory system, the redundancy and the reserve built into the motor system, and the intrinsic foot muscle weakness often goes unnoticed by the patient. So many times, mild dorsiflexion weakness or the toe extensor weakness are not noticed, especially in inherited neuropathies and all, unless you examine. You ask them to walk on heels, they may not be able to do it, but you ask them, they may not complain of any specific weakness. It's a chronic process. The symptoms of autonomic dysfunction, usually the orthostatic intolerance, reduced excessive sweating, heat intolerance, bladder, bowel, or sexual dysfunctions, anorexia, satiety, nausea, vomiting. All these are symptoms of autonomic dysfunction, which will be dealt with in detail. We have one full session on autonomic approach to autonomic disorders. We'll do in detail in there. Then we look at whenever there is a peripheral nerve disorder, we always look at the associated medical conditions for an etiological clue, whether it's diabetes, hypothyroidism, chronic renal failure, liver disease, intestinal malabsorption, malignancy, connective tissue disorders, infections like HIV, leprosy. Drug induced is an entirely a big armamentarium of most of the drugs can cause drug induced liver of neuropathies. Alcoholic and dietary habits like strict vegan diet, exposure to solvents, pesticides, or heavy metals. Occupation, like a toxic exposure to solvents, glues, fertilizers, oils, and lubricants. Sexual history regarding HIV and hepatitis C. Recreational drug use, drug-induced neuropathies can occur. Smoking, especially as a paraneoplastic syndrome, neuropathies can occur. If you have a childhood history of cancers, a poor athletic performance, we should think of a hereditary cause. May not be all neuropathy, could be myopathy also, but when you get something of a hereditary cause. So in a patient with cancer developing neuropathy, the three most common etiologies are either a nutrition deficiency, a chemotherapy-induced or a drug-induced neuropathy, or a paraneoplastic syndrome. There is something called as a posting effect, where they call the toxic neuropathy describes symptoms of progression over months to a year, despite the agent discontinuation. For example, posting is usually seen in chemotherapeutic agents or HIV-related treatment. We all look about surgical history also, because it may not be directly related, but bariatric surgeries can cause nutritional deficiencies, multiple orthopedic procedures, multiple surgeries for entrapped nerves. So all the drug-induced neuropathies, specifically, because this is not exhaustive list, there are much more of drugs which can cause neuropathy. So the common drugs which cause, especially linezolid, if this can cause severe small fiber neuropathy, metronidazole, anyone who has treated the liver abscess knows that it can have a significant neuropathy with it. All the HIV drugs, ART drugs can cause significant. Sometimes it's very difficult to differentiate between HIV neuropathy and an ART-induced neuropathy. It's practically clinically nearly impossible to differentiate between HIV neuropathy and ART-induced neuropathy. So unless you have a temporal association after starting the drug. So amiodarone, colchicine, dalterenone, all these drugs can cause drug-induced neuropathies. The history always should include an impairment on activity of daily living, just like in any other neurological problem. Almost ADL level should always be mentioned in the history, like a change in handwriting, using a daily equipment, stripping in a carpet, difficulty in raising from the commode, or difficulty in getting it from a chair, or difficulty in getting it from. And all these things are a normal routine activities, how they are affecting should be mentioned. And always like history, an examination anyway, you will review. History also, you can get a quick history of the review of the systems, dermatological changes, arthralgias, dry eyes, mucosal brains, constitutional symptoms, all should be given etiological clue. Family history is very important about the ethnic background, consanguinity, and should go into little more details about the family history, just rather than just asking about is there a similar disease in the family. That details about grandparents and siblings, presence of high arched feet, flat feet, hammer toes, skinny legs, or a gait dysfunction. These are all maybe suggestive of an unrecognized genetic inherited neuropathies in the family. And always better to examine family members if you're suspecting an inherited neuropathy. They may have signs which may not be able to pick it up. Family members or history of multi-system involvement, like mitochondrial and all, may have multiple systems involved in the family members. Sometimes it's challenging in adopted individuals, so those with small families, sporadic cases of de novo mutations may not have a definite family history, even though they're genetic. Pedigree is important. Important to know it. We see all sort of funny pedigree charts in rounds. So it is you need to know how to draw a proper pedigree chart, and it has to come spontaneously. So there's no pointing in mugging up 1 week before the exam and trying to do how to draw a pedigree chart. So a detailed pedigree chart of 3 generations is very much essential in the history taking in any hereditary neuropathy. Whether you can find out whether this autosomal dominant, recessive, X-linked, or mitochondrial. Only a full, proper, detailed pedigree chart will help you identify. Regarding hereditary neuropathy, why it's important to identify hereditary neuropathy? One is disease-modifying therapies are getting available, like in familial amyloid neuropathies. In HNPPPs, patients and anesthetists can be warned about risk of prolonged immobility and pressures on peripheral nerves. So when do you suspect a hereditary neuropathy in history or an examination? It's a generalized polyneuropathy with a family history, the lack of positive sensory symptoms but sensory signs on examination. It's a prominent wasting, early age of onset, symmetrical, associated skeletal abnormalities, and slowly progressive course. There are exceptions to all this, and this is the general rule. And other clues will be frequent childhood ankle sprains, toes, touching falls, clumsy during childhood, recurrent foot and ankle fractures, regularly being the slowest child in foot braces, recurrent acral paronychia, calluses, ulcers, probably in sensory problem forms, incidence onset, very slowly progressive course, and early and frequent pediatric surgeries. Sometimes you may not get this one family. Sometimes it's difficult to identify because absence of a family history. There's an incomplete penetrance and decreased expressivity. An acquired etiology of neuropathy may compound an inherited neuropathy. It doesn't prevent a person from having an acquired etiology of neuropathy. And a rapid or accelerated neurological decline, you should always suspect a secondary acquired, even if in a known case of hereditary neuropathies. And they are more susceptible to metabolic, toxic, and other insults such as chemotherapy. So, in a summary, so in the history, you can have the onset, duration, and progression. So the onset is always, neurology is one topic where I think one subject where the definition of acute varies with subspecialties. For a stroke, acute means in a matter of seconds or some minutes or hours, or now it is gone up to 24 hours. In neuropathy, it's an acute is almost up to 1 month. So it is an onset of disease is from the onset to peak of the disease. It's not the total duration of the disease, from the onset of the disease to the peak of the disease. And the duration and the progression, how it is progression, monophysically, continuously progressive, or after sometimes progressing is flattened out, or fluctuation, or stepwise progression. Symmetric or asymmetric at onset, the systems involved. Is there a coexistent human involvement? The location, upper limb, lower limb, there is involvement of trunk or a cranial nerve region. Are there systemic features? What is the drug and family history? Activity of daily living. You're trying to fit into a typical or an atypical. Sometimes you call it as a pure or a complicated disease, or a typical or atypical features. What are the red flags in history which you want to confirm in examination? Those things you should have an idea after the history. So the temporal, the onset, this is just a little about a few causes of acute polyneuropathy. So when you think of acute polyneuropathy, the first thing that comes to us is a GBS, Guillain-Barré syndrome, or acute porphyria, which can mimic like a GBS-like presentation, toxic neuropathies, critical illness neuropathy, vasculitis, and infectious causes all can cause acute neuropathies. Chronic polyneuropathy is a classical, is the diabetic sensory neuropathy. All the metabolic causes, alcohol, toxic drug, and all can cause chronic, the heavy metal toxicities. All the immune-mediated neuropathies are typically chronic polyneuropathies. They can have an acute presentation also. Hereditary neuropathies, all the nutritional deficiencies and vitamin basis toxicity, paraproteinemias, connective tissue disorders, mitochondrial infectious causes are all chronic. In between these, all these things can cause, most of the things can cause a subacute onset polyneuropathies also. So patients with chronic polyneuropathy can also develop subacute worsening due to any other neuropathic process. For example, a typical diabetic sensory motor polyneuropathy can present with a subacute worsening. They can have a coexistent lumbosacral radiculopathy. They could have a coexistent fibular neuropathy. They can have a lumbosacral plexopathy or a CADP. All these things can cause a worsening and already existing a diabetic sensory polyneuropathies. A patient with CMT can also have developed a hereditary neuropathy, can also have superimposed entrapment neuropathy or a second etiology like CADP. We always heard of a double crest syndrome, so a CTS patient having a cervical radiculopathy also. So these are the other conditions of in the neuraxis which can present acutely, which should be that with tongue of a differential diagnosis. So something of the recurrent or lapsing remitting, first thing we'll think of is a CIDP or HNPPP. And porphyria, repeated toxic exposure, and vasculitis. All these things can cause recurrent or relapsing polyneuropathies. So what are the diagnostic clues from examination? You need to get, when you go to the examination, you need to characterize. So you have got some idea about the tempo of onset and duration from the history. You get to confirm in examination whether it is matching with that, whether it's a hereditary versus acquired, it's an anatomical classification, and the etiology. These are the one we are trying to decipher from the history and then from the following examination. The anatomical classification includes, so you're trying to deal with the motor or sensory, the large versus small, and the somatic versus autonomic, the portion whether it's an axonopathy or demyelinating neuropathy, whether you're able to get a clue on that, whether it's a length dependent, length independent, or a multifocal pattern. So neuropathy general physical examination has a very important role, because it will give vital clues towards the etiology of the condition. Orthostatic vital signs will give evidence for the dysautonomia. In the skin and mucous membranes, you got a vasculitic rashes. In vasculitis, you can see rashes, purpura, or alveolar-reticularis. Trichomoniasis can cause purpura. Angiokeratoma is in Fabry's. Hyperpigmentation is in poems. Hyperpigmentation in leprosy. Oral ulcers is in Behçet or HIV. Bullous lesions in porphyria. Salivary gland swelling can be seen in sarcoidosis or in Sjogren's syndrome. Extremity hair loss or gum lead lines can occur. Then Mees lines can be due to arsenic or thallium poisoning. Alopecia can occur due to hypothyroidism, lupus, amyloidosis, or thallium poisoning. Curly hair can giant axonal neuropathy. Distal calf hair loss can be seen in most of the distal symmetric polyneuropathies. So skeletal deformities, hammertoes, pes cavus, kyphus scoliosis are all suggestive for the inherited polyneuropathies. And the peripheral nerve palpation, you look for a nerve thickening. The common sites that you look for is the ulnar nerve at the elbow, radial sensory nerve, the radial wrist, the great auricular nerve behind the ear. So the nerve enlargement can be seen in the demyelinating neuropathy, neoplasia, neurofibromatosis, or in leprosy. Look at the joints for any rheumatological coexisting conditions. Sometimes you can Charcot joint in several sensory involvement neuropathies. Hypermobile joints and elastic Ehlers-Danlos syndrome. Scapular winging can be seen in some of the hereditary neuropathies. Muscle atrophy and contractures usually indicates chronicity. Elbow contractures are usually seen as a myopathic process. Usually we will have a myopathic process will be there. Then contractures, the angle can be occurred due to myelopathic CNS disorder, myopathic process. So you should look at the pattern of involvement. So the system involvement in a hereditary neuropathy, if you can see the hereditary neuropathy, now the CMTs have become more like a HSP-like thing. So you can see, I mean, almost any system involvement in CMTs. So you got the ocular dementia, learning disabilities, optic atrophy, cerebellar syndromes, optional ophthalmoplegias, vocal cord palsies, hearing impairments, neck muscle involvement, and a bunch of involvement of all the different signs and symptoms. So for example, you can have coexistent human involvement, extensor plantars, ulceral mutilated sensory complication, arthrogryposis. So usually you got a dorsiflexion weakness, and if you can get an early angular plantar flexion weakness, a hint 1% neuromyotonia. So all these conditions can be seen. So you need to identify and examine from head to foot as a normal neurological examination to identify, and just not get biased that it's a neuropathy. You can't get anything else of these. The cranial level examination about the anosmia you see in Reflexes and B12 deficiencies. Optic atrophy can be seen in inherited neuropathies and any of these central or peripheral demyelination. Anisocoria and the pupillar reflexes can be seen in parasympathetic dysautonomia. Impaired ocular motility seen in botulism and Miller-Fisher syndrome. Can give facial weakness due to facial nerve weakness and the trigeminal sensory loss. We'll come to that. And hearing loss can be seen in mitochondrial and bulbar involvement can usually seen in GBS and other syndromes. So facial nerve involvement, the neuropathy with facial nerve involvement, which the commonly involved conditions are: one is Guillain-Barré syndrome, then sarcoidosis, all the infections, leprosy, HIV, Lyme. Syphilis is a little controversial. Syphilis can cause facial nerve neuropathy, but it's usually said that syphilis doesn't involve peripheral nerves. Leukemia, lymphoma, it's a very common condition to see infiltrative conditions like, especially in acute leukemias and acute ALL and acute AML leukemia syndromes, to have peripheral neuro and facial nerve involvement. Leptomeningeal carcinomatosis, GP and Sjogren's, the connective tissue disorders, Jelson-related, the Finnish amyloidosis, Stange's disease, CIDP. CIDP is less common, around 10 to 15%. Mostly in AIDP is very common, 70%. CIDP is very lesser compared to AIDP. And you have a recurrent ipsilateral facial neuropathy, so always think of facial schwannoma, parotid tumor, or acoustic neuroma. Or if in immune-mediated condition, think of sarcoidosis, and other things are Merkel-Rosenthal syndrome. Bilateral facial neuropathy, think of GBS, sarcoid, HIV, and most of the other conditions, leptomeningeal, lymphoma, leukemia, Lyme, and all can cause bilateral facial palsy. So trigeminal neuropathy, along with the peripheral neuropathy, Sjogren is the first thing should come. If you ask for one cause, first thing should come to the mind is Sjogren syndrome, especially the perioral paresthesias and sometimes lingual paresthesias and sensory loss is more likely to be a Sjogren. Other causes are diabetes mellitus, leprosy, infections, leukemia, lymphoma, leptomeningeal granulomatous, Naegeli-Honsel like Postman syndrome, drug-induced, Tangiers, Fabry, celiac, all these things can present with trigeminal involvement. Now, which systems are involved? Motor, sensory, autonomic, or combination? It's a motor predominant neuropathies, more like a living in porphyria, lead poisoning, or multifocal motor neuropathy. GBS and AIDP and AMAN are predominantly motor neuropathies. Sensory symptoms, maybe their signs may not be there that much. CADP with the predominantly motor component, maybe can present with motor predominant neuropathies. And mimics, there are a lot of mimics. This is when you think of a pure motor neuropathy, you should think of an anterior-Honsel disorders and try and look for other signs of anything of anterior-Honsel disorder is there or not. Major differential of pure motor is in a motor neuron disease, MMN, and distal myopathies, especially when we have distal features. Always look for UMN plus LMN features. Focal involvement and wasting, think of multifocal motor neuropathy. Even in MMN, they may have mild sensory symptoms, but they may not have clear sensory signs. The autonomic neuropathies, diabetes is the most common cause. GBS can have other toxics, drug-induced cisplatin, vincristine, and all can cause significant autonomic neuropathies. Paraneoplastic and immune-mediated causes, some hereditary causes, infectious, and neuropathies related to amyloidosis. This will be dealt in subsequently in the autonomic neuropathy session. Now, common sensory system, which is the most common sensory prominent neuropathies. We have both sensory neuropathies and sensory ganglionopathies. Sensory neuropathies are mostly diabetes, toxic, amyloid, vasculitic, HIV, paraneoplastic, immune-mediated, chemotherapy, B6 toxicity, Friedreich's ataxia, and infectious causes. Most of the same causes can cause ganglionopathies also, but most commonly are paraneoplastic, the immune-mediated like Sjogren's, chemotherapy-induced, pyridoxine toxicity, infections, some amount of Miller-Fisher syndrome because of encephalitis overlap can cause ganglionopathy. The canvas syndrome, cerebral ataxia, neuronopathy, and vestibular reflexes syndrome can also involve the gangliomas. Now, coming to the motor system examination, we're not going to individual how to test the muscles or something, but at least few clinical pointers to that. So the most neuropathies cause distal weakness. The intrinsic foot muscles are affected first, the clawed feet or hammer toes. the weakness of flexion extension of small toes and weakness of great toe extension are affected. They may not complain initially if there's a mild weakness. We may get on examination. There are reports saying that in the literature says that angle between the shin and unsupported foot should be approximately 130 degrees. A larger angle status angle dorsiflexion weakness. It just shows that the weakness of the dorsiflexion. Always observe the gait, how they stand up from a chair without the use of hands to push up. The walks on toes and heels. In a length-dependent neuropathy, patients more have difficulty in heel walking than the toe walking. So the examination clues, we have the pes cavus, the hammer toes, the inverted champagne bottle appearance. I'm not showing a lot of pictures or videos in this because we'll do it in the last and final video session that we have in the final session. So we'll cover all those features in there. So what are the clues towards a hereditary neuropathy? This is a foot drop identified by a doctor but not appreciated by the patient. There is a high arches of hammer toes, inverted champagne bottle appearance, sensory loss without sensory symptoms, palpably enlarged nerves, and exuberant plantar callus from angular valgus or varus deformities. Now coming to the sensory system. So as Neeraj discussed before, small fiber, you have a loss of pain and light touch. Large fiber, you have a loss of proprioception, JPS, and vibration. Light touch usually evaluates the low threshold mechanoreception. Usually you can identify using a monofilament 10 gram that usually endocrinologists use. We usually substitute with a light cotton, with a light cotton touch. But whether the sensitivity or specificity of monofilament with a vibration is pretty good in identifying a high-risk diabetic foot. But we don't know the exact whether the light touch can easily identify. Usually a cotton light touch has got the same sensitivity. It is not known. But difficulty for patients who have difficulty in differentiating between the sharp and a dull stimuli, it is basically due to loss of nociceptive fibers related to the low threshold and mechanoreceptive fibers. In sensory ganglionopathy, will have severe proprioceptive loss compared to other involvement of a large fiber or a posterior column. More of proprioceptive loss, severe proprioceptive loss is usually seen in a ganglionopathy. We have seen the pseudoathetosis piano playing fingers in sensory ataxia. And testing, a few points in testing. When you test for pinprick sensation, it's always start from the area with the suspected sensory deficit and move to the area with the normal sensation. And you should avoid touching the pin on patient's skin repeatedly. Don't keep on poking in the same area to avoid the temporal summation, and always try to keep the intensity of the pressure at which we are switching keep uniform throughout while we're testing. We have one so that it could be reproducible and it can be objectively monitored. For the vibration, we usually use the 128 Hertz and the time interval until the perception of vibration loss is measured. Usually it's been considered that a young adult can appreciate vibration of the great toe for a minimum of 15 seconds. This value may decline by 1 second per decade. But usually, what you can do is you can try and compare with your own, provided your own vibration is normal. So they can compare and see whether it is happening at the same level or not. But any vibration perception less than 10 seconds in the great toe is abnormal at any age. And so the usual sites are toes, dorsal of the foot, ankle, mid-shin, knee, hip, anterior spine. You get the sites of testing, the distal phalanx of the finger, knuckle, wrist, elbow, and shoulders. The joint positive sensation is less sensitive than vibration testing for large fiber, may only be impaired in severe cases. Usually test the large toe and the second finger at the distal interphalangeal joint. Always hold at the lateral borders, and the movement escalation should be minimal. Don't hold it don't hold it up down. So you always hold at the lateral side. The proximal joints are tested if the distal impairment is present, and the speed and degree of passive joint movement should also be consistent. So the three major differentiating points when you have a sensory ataxia is our sensory loss, is the large fiber loss, is whether it's a large fiber neuropathy, a ganglionopathy, or a posterior column fibers involvement. In a large fiber, there will be length dependent loss of reflexes. Ganglionopathy, there is a diffuse loss of reflexes because you get an involvement of the all ganglion. Ganglionopathy is almost like a sensory counterpart of a motor neuron, anterior motor neuron disease, a sensory motor neuron, counterpart of a motor neuron disease. And the posterior column, you get a reflexes plus minus depending upon involvement. Graded sensory loss and symmetric involvement is usually seen in large fiber. This is taxisensory loss. It will be asymmetric, sometimes truncal, proximal, facial, trigeminal sensory loss. All these things can occur in a ganglionopathy. You may get a vertebral level for the vibration. You get a girdle-like sensation due to the posterior column involvement. You may get a Lermit sign. Sensory ataxia is the most severest in sensory ganglionopathy, and the Romberg sign will be positive in all three. And the sensory deficit in leprosy, as Neeraj has already mentioned, affect the polar area of the body. And the Tangiers disease can present with bifacial weakness and the proximal sensory loss, like a syringomyelia-like presentation. Some porphyria also can present with an early severe proximal weakness. The proximal pattern of sensory loss is called a bathing trunk pattern. And syringomyelia-like pattern also seen in a neuronopathy, both focal motor, sensory and motor neuronopathy called Forsman syndrome. We can have a trigeminal distribution initially, then later on can involve the motor symptoms can occur later on. Now coming to the reflexes, angular hyporeflexia, reflexia is common in large fiber neuropathy. It's usually part of the it's a length dependent part. It can involve in the distal part of the affected first. Then it's usually preserved in the small fiber neuropathy. And reflexes are usually preserved in maybe in a mild to moderate large fiber. Just because a large fiber reflexes may not be absent in the initial stages. Reflexes diminish with age. They say that absent angular age of 80 may be normal. That's a controversial thing. Some people don't believe that age, there's a normal aging pattern, whether it will affect or not. Some may not accept that. Then preserved angular reflection leprosy and hyperreflexia in GBS, this and loss of reflection and length. These two factors, the first two have been discussed by Neeraj. And loss of reflection and length dependent neuropathy and generalized reflexia. These are all being clues towards for whether it is a large fiber neuropathy, the length dependent, or a generalized reflexia happens when there's the etiological clue, there's a ganglionopathy or an demyelinating neuropathy. It will help you in the etiological clue. Now, always look for evidence of an upper motor neuron involvement. For example, pure motor, think of anterior motor neuron disease. When there's a sensory involvement, you look for vitamin, and along with that, it's a human involvement. Look for vitamin B12 deficiency, copper deficiency, vitamin A deficiency, HIV, ferritic ataxia, adenomyeloneuropathy. These terms, and if there could be an unrelated human, an old stroke or cervical compression, something unrelated coexisting with the neuropathy. Some clinical points: when you have a bilateral carpal tunnel syndrome and autonomic dysfunction, you think of amyloidosis. The same like you think of a dysautonomy and a proximal weakness, you think of LEMS. So sometimes this is something which we usually see. I mean, everybody would have seen it. Some patients with pure sensory neuropathy which have a normal motor nerve conduction study, but still they will have some subjective complaints of weakness. Usually seen as very sensory attacks and very sensory neuropathy. Because of the lack of the sensory feedback, they may have a subjective sensation of weakness, and though there is no objective sense of weakness. The same thing happens in the pure motor neuropathy, like multifocal motor neuropathy. May have some sensory symptoms, but they not have objective sensory loss. So you shouldn't get carried away with it. And whenever there's a shoulder pain, there's always the range of motion of the shoulder should be checked. Presence or absence of scapular winging should always be documented. So when we have a shoulder pain, you say in Parkinson's, same thing. If you have a shoulder pain, in some amount of hereditary disorders, even some conditions like FSHD and all. When you have something with shoulder pain, restricted movement, you should be the differential should all be there. When you have a pure motor syndrome. In critical illness neuropathy, when there is critical illness neuropathy or myopathy, when you have a development of weakness over days is involved, it's usually more likely to be critical illness myopathy, but it can cause critical neuropathy also, but usually more something weakness developing over days is more likely to be a illness myopathy. Now coming to the symmetric lower limb distal weakness, lower limb more than upper limbs, sometimes in a very chronic process, sometimes it may be difficult to differentiate between a chronic neuropathy and a distal myopathy. So one clue is the early involvement of the intrinsic hand muscles is more likely to be seen in distal hereditary motor neuropathy as compared to the forearm flexors, which is involved in a distal myopathy. So which we had the features in clinically, how do you differentiate between a demyelinating and an axonal neuropathy? They have a weakness without much atrophy. You know the mechanism behind that, the length dependent distribution, then early with a with a proximal predominant or asymmetric patchy distribution, early involvement of a proximal reflexes. That means generalized loss of reflexes is more likely to be demyelinating neuropathies. Presence of myokemia, which is usually seen both in the central and peripheral demyelination, and pacrally enlarged nerves and a neuropathic tremor. These are more such of a demyelinating neuropathy. The distal reflex loss and preserved postural reflex are more likely to be seen in an axonopathy. So some other points when you look for when you round up the examination process, you want to know whether the neuropathy is symmetric. After that, want to know whether it is a length dependent or not. Then about the sensory involvement. Other points and things is even the sensory and the length dependent. When it comes to the anterior chest, so the nerve fibers comes to the longest part of the nerves in the chest is in the anterior part. So you may get an anterior. Sometimes it may even get a tend up sensory loss on the chest. It's called the tend up sensory loss in the anterior part of the chest because of the nerve fibers involved. The length dependent, the lengthier, the longest fibers of the chest are in the anterior part of the chest, so they may get involved in the length dependent neuropathy. In the motor, the intrinsic foot muscles cause toe flexor weakness and floor toes. Anterior tibial compartment involvement can cause dorsiflexion weakness. The plantar flexion are relatively preserved. I told previously also why usually you have a length-dependent neuropathy is walking on heels is usually difficult and usually more difficult than walking on toes, because possibly because of the functional redundancy of the large bulk of the posterior compartment, and the intrinsic hand muscles are involved only after the calf muscles are involved. So there's a length dependency in the length-dependent neuropathy in the motor component also. The motor weakness is usually greater in the extensor group than in the corresponding flexor group neuropathies. So a neuropathy with significantly early proximal involvement raises the possibility of a demyelinating neuropathy, which is usually we can think of as, if it's a chronic process, we think of CIDP. One particular clue is if you have a significant hip flexor weakness, so it is very difficult to localize between it to coexist in any other radiculopathy involvement. Usually, if you're suspecting CIDP, hip flexor weakness is a good clue to corroborate your other findings. And sometimes demyelinating neuropathies can mimic a length-dependent neuropathy because, in a way, ultimately it's the longest fibers anyway has a propensity to get affected more due to other factors also. A sensory involvement of the lips and mouth is more of a length-independent process. And a celiac neuropathy, which I mentioned that the facial sensory symptoms also sometimes may cause a trigeminal and a facial sensory involvement, something which we don't usually see very commonly. So coming back, so this is the mainly for an history and examination part. Then we come to the pattern recognition part. So history, in the pattern recognition, after the history and examination and the functional using a good functional neuroanatomy to try to differentiate whether it is a CNS or a PNS lesions, and you identify the different various patterns, whether which PNS structure is involved, is it multifocal or generalized, is it sensory or weakness, sensory loss or weakness of both, is it proximal or distal, is it symmetric or asymmetric, and if whether it is an acute or subacute. This is what you have got from the whole history and examination part. You try to summarize everything together and try to look at the pattern and try to arrive at a differential diagnosis and localize under differential diagnosis. Let's go one by one. CNS or PNS, clinical points. The lesion in the brain or brainstem, one thing is rare to cause pain. So unless there are exceptions of central post-stroke pain. When there is a pain, you think of a peripheral cause. And the hyporeflexia in a symptomatic limb suggests a peripheral lesion, whereas a breast reflex in a symptomatic lesion and is a central lesion or a coexisting central lesion. If all the signs and symptoms are in a single limb, both central and peripheral localizations are possible. Usually hemibody symptoms, usually it causes a central localization. It's very difficult to get a peripheral localization with one side of the body fully involved. Length dependence can be, we saw the Neeraj describing how the pseudoneurotic pattern can occur. And the sensory long, and if the sensory loss spreads up from the, even if it is pseudoneurotic, if you think of pseudoneurotic presentation, if the sense spreads up from the feet up to the groin or trunk, and still going up to the groin and trunk, still the upper limbs are not involved, then you always suspect a spinal cord pathology. So any CNS localization, which we know is a breast reflexes in upper affected limb, increased tone in an affected limb, sensory and motor symptoms limited to two limbs to the same side of the body, weakness in the extensors in the upper extremities and flexors in the lower extremities, a typical seen in a human lesion. Spinal cord localization is a horizontal truncal sensory level. A decreased pain is a Brown-Séquard like presentation, or a decreased pain presentation on one side or diminished proprioception on the other side. Dissociated suspended truncal anesthesia. This can occur only, can localize only towards the spinal cord. And a peripheral localization, which we discussed in most of the things just now. So patients with an upper extremity weakness due to a CNS lesion, this is usually a peripherally involvement of the extensors, like the triceps and the wrist and the finger, the typical positioning of the upper limb in a human. In a stroke, we have this typical human presentation. If you, for a theoretical discussion, you can say that if obviously a tone is increased, you can be able to identify. Other than that, a proximal radial mononeuropathy can also affect these muscles, the extensors. How to rule out, one point is to look at the strength of the brachioradialis, which will be reduced in proximal radial mononeuropathy, but relatively spared in a CNS lesion. Patients with leg weakness involve weakness of the flexors like iliopsoas, hamstrings, and tibialis anterior. No single peripheral nerve lesion can affect these groups of muscles, so it's easy to identify. Now coming to the focal symptoms, you need to know when you have a focal symptoms, the pain, sensory loss, and weakness in the focal structures could be either radiculopathy, plexopathy, or mononeuropathy. So for that, you need to know the detailed functional neuroanatomy of the nerve root, the plexus, and the nerves, which will be discussed in each of the subsequent sessions. But for a radiculopathy, you need to know the knowledge of the neuroanatomy, sensory symptoms of each root, the motor, the myotome, and the dermatome, so that you identify the causes. So I'm not going into each root and which are the roots and the plexus involvement. In the plexus of localization, the pain, weakness, and atrophy are the most common. The triad of pain, weakness, and atrophy localized to the one limb, and or sometimes you get a bilateral plexopathy to both limbs, and the sensory loss affecting that depending upon the pattern of nerves involved. Usually asymmetric, focal, sometimes multiple contiguum and multiple contiguous nerves are almost always involved. Most common cause is a trauma, especially in brachial plexopathy. Road traffic accident trauma is the most common cause. Other than that, in acute onset, you think of an inflammatory or a metabolic. In serious onset, you think of an infiltrative or radiation. And same thing in the upper limb, you can have other hereditary conditions like hereditary brachial plexopathy or HNPPP can also present with a brachial plexopathy-like thing. Sometimes they may have coexisting root aversions also. Physiologically we can do, and it has been a management pattern that we'll discuss in the approach to plexopathy session. Again, the lumbar plexopathy, I will just skip it because we have a lot of things to cover. Mononeuropathy, look at the entrapment sites, the median nerve at the carpal tunnel, ulnar nerve, the elbow, radial nerve, and the spinal groove, fibular nerve. So the common sites where you can see an entrapment mononeuropathy. Other causes of mononeuropathies are trauma, ischemia, compression by the tumor, infection, radiation. You get both motor and sensory of the affected nerve. Sometimes you may get a pure motor mononeuropathy, like a suprascapular nerve, anterior interosseous nerve, or the posterior interosseous nerve. Sometimes a mixed nerve, the sensory fascicles may be spared, like an ulnar neuropathy, neuropathy may not get clinically a sensory involvement. But a pure motor radiculopathy, theoretically it is possible, only to use involving the ventral root, but usually very rare. The pure sensory, superficial radial nerve or the medial or lateral antebrachial cutaneous nerves, the lateral femoral cutaneous nerve, saphenous nerve, sural nerve, or the mixed nerve involved in predominantly sensory, like we usually see in early stages of carpal tunnel syndrome, can also cause pure sensory mononeuropathies. Now look at a few some of the patterns which can affect, which we can identify. For example, a proximal asymmetric involvement, as we told, is going to be a proteal radiculopathy, radicular neuropathy, or a radicular plexopathy. Common causes are malignancies, lymphomas, sarcoid infections, or an HNPP-like presentation. Proximal and distal symmetric involvement. If you have symmetric, it could be root and a distal peripheral nerve. Classically, you've seen in AIDP or demyelinating neuropathy, AIDP or CADP. Proximal and distal asymmetric is usually the classical presentation of a mononeuritis multiplex, or now called a multiple mononeuropathy. More than two peripheral nerves, most often not at an entrapment site. But a pain, sensory loss, weakness. The most common cause are vasculitis, leprosy, HIV, diabetes, lymphoma, MADSM, and HNPP can also get present. Later on, confluent mononeuritis multiplexes may present like a general. You examine like a lesion may present like a generalized polyneuropathy. But one point to note is, even if one nerve is involved, if it is a non-entrapment site, always look for other causes of a mononeuritis multiplex. The differentials of an asymmetric involvement is mononeuritis could be an axonal or a focal demyelination. Axonal, which I told, vasculitis, diabetes, sarcoid, leprosy, and infections are all mostly axonal. Demyelinating can be MADSM, MMN, multiple compressive, HNPPP, and lymphoma can also present with the demyelinating neuropathies. Asymmetric neuropathies, all these things, all the same things can cause asymmetric polyneuropathies. When you have a focal thing, always consider the mimics like an ALS or a FSHMD, which can present with an asymmetrical pure motor presentation, which you think of. Always think in the back of your mind, you should have these differentials. An adult patient CMT may have asymmetric weakness, probably because they have a superimposed radiculopathy or entrapment neuropathy. So multiple compressive neuropathies can have occurred already in a predisposed individual. For example, diabetic neuropathy or alcohol neuropathy can have multiple compressive neuropathies. Coming to a distal symmetric pattern, it could be a length dependent. A distal sensory polyneuropathy is the more diabetic or diabetic polysensory polyneuropathy. Sensory predominance is the most common. Sensory loss, weakness, loss of reflexes, everything will be length dependent. The involvement is length dependent. Sometimes atrophy of the EDB may be evident even before you may get a clinically relevant weakness. Diabetes, prediabetes, B12 deficiency, paraproteinemia, drug-induced toxic are the common causes of a distal symmetric polyneuropathy. Sometimes motor may be more predominant, hereditary like CMT, young onset, positive family history, high arch. You may get a motor predominant distal symmetric polyneuropathy. Even though sensory on examination you may get. That will usually have a motor and sensory, and then sensory predominant is one thing which we'll cover in the immune-mediated neuropathy section. So the next is a pure motor, proximal and distal symmetric. When that such a thing occurs, CIDP is one which is we can present without sensory loss. Always think of other different conditions, myopathies, neuromuscular junctions, anterior hornsel, which can have a proximal involvement, Kennedy's, all these things which would be in your differential diagnosis. In the pure motor, proximal and distal asymmetric, usually in ALS and variants, infections, And these are the differentials on that. CADP variants can, or it's called as atypical CADP or CADP variant, can cause asymmetrical proximal and distal involvement. So almost some of mostly neurogenic, except something condition like IBM and FSHD can cause both. Distal symmetric motor involvement, hereditary neuropathies usually seen in CMT, sometimes in axonal CMT, the differentials of juvenile ALS or HSP can also mimic or differential to that. You and to identify a distal myopathy, the distal neuropathy in a chronic process, we say EDB is one point towards that. Sometimes the involvement of the finger flexors involve more in a distal myopathy compared to intrinsic hand muscles in a distal neuropathy. Again, distal asymmetric, usually ALS versus multiple motor neuron MMN is a common difference that we have. Usually it's a pattern recognition of a multiple nerve pattern recognition with a myotome recognition. MMN usually weakness out of proportion to atrophy, hyporeflex, areflexia, there will be no bulbar or respiratory involvement. Other differences like Hirayama and flagellum weightage must be considered at that point of time. Regarding pure sensory, when you have a pure sensory involvement, always look at all the localization for pure sensory from the spinal cord sensory tracts to dorsal ganglia to sensory nerve to small unmyelinated fibers. Most clinically significant lesion will cause static sensory loss when you have a bias. When you have sensory radiating from multiple places, it's less likely to be neurologic entity, but always keep your differentials open. Pure sensory, both proximal and distal symmetric, which we discussed most of the causes of localization of dorsal column ganglionopathy and large fiber neuropathy. The ganglionopathy is the one which we discussed as which can have a proximal sensory loss, facial sensory loss, asymmetry, severe sensory ataxia, and pseudoathetosis. And there's some kind of entity called a Wartenberg migratory sensory neuritis. I have not seen it. But this is supposed to be an autoimmune condition where you get migratory sensory neuropathies. Then there's something entity of a pure sensory distal symmetric. It's a classical of a distal small fiber neuropathy, distal sensory polyneuropathy and small fiber neuropathies. Pain and temperature and autonomic fibers are length dependent. Paresthesia, neuropathic pain can occur. Painless injuries. Pain and temperature affected first. Usually preserved large fiber sensation, preserved motor fibers, preserved reflexes. Autonomic function testings are abnormal. So the classical features of a small fiber neuropathy. So in a summary, the 6 key questions that we need to answer is which systems involved, what is the distribution of weakness, is a distal or proximal, if it is distal, is a focal or asymmetrical versus symmetrical, or focal, distal, focal or asymmetrical versus symmetrical, what is the nature of sensory involvement, pain or burning, or the small fiber or the large fiber, is there an evidence of coexistent upper motor neuron involvement, what is the temporal evolution? Is an acute subjective chronic? Is there an evidence for a hereditary neuropathy? Once you answer these questions in your history and examination, you will get a pretty much good grip of what is the localization and what are the etiological and differences that you need to consider. The summary of how to differentiate between an inherited and an acquired is an insidious and a chronic course in inherited. Acquired is an acute subacute onset. Sometimes you will get a chronic onset also. Distal more than proximal. Sometimes, depending upon the acquired condition, you can get both. Proximal more than distal or distal more than proximal. Wasting and weakness. Wasting is more prominent and weakness more than wasting in an acquired condition. Sensory signs more than symptoms. Sensory symptoms and signs are more equally present, or symptoms more than signs. Obviously, the family history, positive inherited disorders, musculoskeletal deformities are there. And in electrophysiologically, we get a conduction slowing. Uniform conduction slowing inherited, where you get a conduction block and temporal dispersion is usually present in the acquired polyneuropathy. Now coming to the investigations, I will not go into much into details of the investigations. We will consider more of a generalized thing, because in each session, whoever is dealing with that will go in depth into the approach of those conditions and how to work up for those cases. But in a common an overall outlook of investigations is you do what are the armamentarium that we have in an approach to a peripheral. You have blood tests, you would have a CSF analysis, you have a electrodiagnostic testing, you have an imaging, and you have a tissue biopsy, nerve biopsy. The blood investigation, the purpose of blood investigation is usually to identify a systemic disorder that could cause or put the patient to a neuromuscular syndrome, and in a hereditary neuropathy to identify a genetic cause for that. In a distal symmetrical polyneuropathy or distal sensory polyneuropathy, the essential 4 investigations that we should get it done for most of our patients are the diabetes has to be ruled out, the lipid profile, the metabolic profile of those along with the diabetes, the serum protein electrophoresis, and the immunofixations. Immunofixation should be done, not just the protein electrophoresis. Dr. Deepak will discuss in his talk why the importance of that. The B12 and MMA, there's a functional, even the B12 levels are the normal, the functional deficiency is there or not, MMA should be done. Methylmalonic acid, which should all levels also should be done if you're suspecting a B12 deficiency. In a mononeuritis multiplex, you do a blood counts and the basic metabolic panel, HbA1c, HIV, hepatitis panel, ESR and CRP for the autoimmune process and the autoimmune markers of the DNA profile and complements and the cryoglobulins. If you're suspecting a multifocal motor neuropathy, GM1 ganglioside antibodies can be checked in 50%. In CIDP or a DADS, obviously as I told before, the electrophoresis and the immunofixations, the IgM paraproteins look for if you get an IgM, you look for anti-MAG antibodies. If you get an IgG, look for poems. VEGF is one factor which will help you in localizing for the poems. One of the criteria for the poem syndrome. In ganglionopathy, if you're suspecting, most common cause is a paraneoplastic. You look for the paraneoplastic, especially anti-WHO antibodies. Jogren is a common cause, is an SSSB, HIV, and if you're suspecting a pyridoxine toxicity, you can check pyridoxine levels, or you can stop the pyridoxine. In AIDP, we classically describe the CSF albinocytological dissociation where the protein is more than 45, the cell count of less than 50 cells. The cell count 50 is a little controversial. Some people don't accept. We want a cell count of less than 10. Up to 50 is not. 10 to 50 is it's a no man's land. Maybe abnormal in the. It can be abnormal. It can be normal in the first week. If you're suspecting cells more than 10 cells or more specifically more than 50 cells, think of infectious causes like HIV or CMV. In CIDP, proteins are elevated, but one caution for CSF examination in CIDP is in the absence of clinical and electrodiagnostic criteria, CSF protein should not be a justification to give an immunomodulatory therapy in everything. So otherwise, to start doing that is the only criteria and see in neuropathy whether it is a treatable cause is there or not. If there is CSF protein is elevated, let's give a chance and give an immunomodulator. That should not be idea. That CSF protein should not only be that should not guide your treatment protocol if none of the electrophysiological or clinical criteria is satisfying the CIDP. Role of NCS and EMG, I'm not going to details of that, but what is the plan? What role do they have in a polyneuropathy? To confirm the presence or absence of a large fiber neuropathy, to identify the prominent nerve fiber involvement, to demonstrate the existence of a superimposed compression neuropathies or radiculopathies, to know the distribution of the nerve involvement, to identifying the underlying pathophysiology, whether it is axonal or demyelinating, determine whether it is symmetry or asymmetry, to determine the severity of the polyneuropathy. So you may get a significant clue towards whether it is an acquired or inherited. Sometimes you can follow it up with the patients with the stability, worsening or improvement of polyneuropathy and to monitor the therapeutic interventions in polyneuropathy. These are the usual indications or the utility of a nerve conduction study in a polyneuropathy. Now the MRI part, I'm not shown any of the electrophysiology or the MRI pictures because most of the things we'll show it in the video session. So the MRI, you can say hypertrophic or enhancing nerve roots in patients with demyelinating polyneuropathies such as AIDP, CIDP, or CISP, chronic immune-mediated sensory polyneuropathies. And then dynamic MRI, if you're thinking of a Hirayama, focused MRI of the brachial plexus or a lumbosacral plexus can help in identifying the etiology of the plexopathies. Nerve biopsy, which is becoming, we are doing less and less commonly in nerve biopsy. To be honestly speaking, the only main reason we do nerve biopsy, these are the 5 conditions, whether it's a vasculitis, amyloidosis, neuroinflammatosis, leprosy. Sometimes suspecting if you are sarcoid, we don't have any other clue, sometimes we do. So most of the other, we have stopped doing it for previously we used to do it for CIDP, we have practically stopped doing it for CIDP now. Skin biopsy can help in a lot of small fiber neuropathies. We'll be discussing later in the small fiber neuropathies there. And genetics, we see the gene panel. So sometimes you do the most common CMT1. If you don't get, you do the CMT panel, then do the exome sequencing and the whole genome sequencing. This will be discussed in the next session of the approach to inherited neuropathies. So concluding, so history and examination is the most important thing, and general physical examination can give key clues towards the etiology. Localization and neuroaxis is the key step. Pattern recognition is important to narrow down the differentials, and use of investigations in neuropathy is judiciously, and don't go for a fishing expedition. If you start for a fishing expedition without having a definite localization, different etiology in mind, you may get unnecessary false positive finding and go chasing those investigations. Thank you.
Thank you, Dr. Vishnu, for emphasizing the importance of peripheral examination. I always tell students in neuropathy you should spend more time in peripheral examination. It gives a clue for the etiology. You emphasized that point very well.
So I will just stop share. I'm just stop share, or is it still sharing?
You go for questions.
Yeah. There are a few questions. Let's see. Okay, how to work up for a non-localizing ulnar neuropathy on NCS in a non-diabetic patient. That we will discuss. We are discussing the mononeuropathies in details in the. Dr. Shruti will be discussing the mononeuropathies and multiple mononeuropathies in details. In each nerve, we'll be discussing that. We'll discuss it there. Is girdle-like sensation due to posterior column or a spinothalamic involvement? The girdle-like sensation is classically described due to the posterior column involvement, not due to the spinothalamic. Spinothalamic tract will have a dull, bore aching, deep aching tract pain. The girdle-like sensation is more towards a posterior column involvement. Does it have any localization value or a false localizing sign? It is very difficult to localize to a particular segment, but it will otherwise it can help you in identifying. One thing is towards the spinal cord. Localizing to the spinal cord can be done to this one, but girdle-like sensation can occur a couple of segments down also. So you can't exactly point towards that particular level, but at least it will help you in localizing to a one thing is for involving in your posterior column and involving into a spinal cord. Then the cause of neuropathy starts predominantly involving the upper limb. The upper limb involvement predominantly is the multiple MMNCV, multiple motor neuropathy or mononeuropathy with multiplex can involve in the that usually presentation is in the upper limb. But if you ask which is the most common cause of upper limb mononeuropathy, it is the carpal tunnel syndrome is the most common cause of neuropathy which affects the upper limb, and all the ulnar neuropathy causes mononeuropathies causing the radial nerve neuropathies, which can cause most of them can present with an upper limb prominent involvement. Is CIDP distal or proximally predominantly? CIDP is involved in both proximal and distal component. Both are involved equally. There can be an asymmetrical involvement. There can be, but there should be a significant proximal component in CIDP. So if you see a hip flexor weakness in a suspected CIDP person, then you can at least you get some clue that there is significant proximal weakness is there. There can be CIDP variants. We have now the arrival of all the nodopathies and the paranodopathies and all these things have expanded the spectrum of the CIDP variants. There are a lot of atypical variants are there. You have focal CIDPs. You got the DADs. So if you have predominantly a distal variant, for example, DADs is the anti-MAG variant, or that can cause predominantly a distal predominant demyelinating neuropathy variant of that. Dr. Deepak will be discussing in detail about the CIDP, the variants, the clinical features, how to approach it. Next is how to treat a patient with diabetic plexopathy. Diabetic radiculoplexopathy or diabetic amyotrophy, the exact etiology is still not known. It is supposed to be a microvasculitis pathology, microvasculopathy or a microvasculitis pathology. The trial was initially, I think the DIC in UK did first trial on medial prednisolone on diabetic amyotrophy, still not published. He had around 75 patients long back. It was just published as an abstract. I don't think it was published since then. So usually there are two, because of the concept of microvasculitis, you give a steroids or an IVIG are the two components which people use to treat it. But the most important part of both, whether it is steroid or IVIG, before that, both of these drugs is the control of blood sugars. The control of blood sugars is usually seen in very high blood sugar and poorly controlled severe pains. And the first thing part is to control the blood sugars. I have treated with both steroids and both IVIGs, but I can't vouch for the efficacy because anyway, both of them will improve whether the patient is improving with the natural history or we are doing the treatment history. Unless you do a randomized control trial, is very difficult to find out. Now the tremor, I think Neeraj have explained why neuropathic tremor occurs, the mechanism in neuropathies. Then about clinically differentiating between distal myopathy and neuropathy, yes, if you have classes, if you have the reflexes preserved, you can say that it is there. You will an EDB hypertrophy, reflexes preserved, pure motor, then you can easily say that it is a distal myopathy. Sometimes it is not easy. In a chronic patient, severely atrophic limb, in a distal myopathy also you may not get reflexes. So in those conditions, that one thing which you can help is, one is the skeletal deformities, which you usually seen in hammer toes, pes cavus, scoliosis. Those will help you more towards a distal hereditary neuropathy than a distal myopathy. EDB hypertrophy will definitely towards the distal myopathy. And look at the hands. Look at the hands. If you have a distal myopathy that's severe enough to differentiate between that's severe enough to making it complicated to differentiate between a neuropathy and myopathy, hands are involved. Look at if the intrinsic hand muscles are involved, is more likely to be a distal hereditary neuropathy, and if the forearm flexors are involved, is more likely to be a distal myopathy. Then about proximal neuropathy and myopathy. Proximal neuropathy and myopathy distance, it depends upon if the sensory is involved, then it's easier. If it is a proximal motor involvement, it usually is due to either radicular involvement or due to a plexus involvement. In plexus, there is likely to be a lumbosacral plexus involvement. You will get some amount of sensory. Sensory is difficult to localize in upper limb plexopathies. The sensory involvement is a little more easier to delineate. In lower limb plexopathy, you may not. Is that not as easy as in upper limb plexus, brachial plexus to localize the sensory loss in a lower limb plexus? But if you get a sensory loss, then it's not much difficulty different between myopathy and neuropathy. Now, if you don't get much sensory loss, and this is then it's a pattern of muscle involvement. You get it's a definitive pattern following the neuroanatomy of a plexus or a radical or a difficult radical, it is more likely to be a radiculopathy or a plexopathy. And if it's involving a specific pattern of muscles are involved, doesn't follow the pattern, it's more likely to be a myopathic involvement. And depends in myopathy also depends upon inherited or the acquired myopathy. In acquired myopathy, you will not get a specific patterns involvement. In hereditary myopathy, you will get a atrophy and hypertrophy in the same muscle, or a difficult pattern recognition pattern in the myopathy. So it's a different topic altogether. So whether the adductors are more involved, hip flexors are more involved, or the knee extensors are spared and knee extensors are involved. So that pattern will definitely help you in identifying the muscle regarding the myopathy part of it. Then role of steroids in traumatic neuropathy or duration. I'm not sure about the evidence base behind that, because you routinely don't treat a traumatic neuropathy as such. I don't know if Neeraj knows about the role of steroids. He has recently reviewed or something. Do you know about that?
The role of steroids, although I have seen giving steroids in traumatic neuropathy, but pathophysiologically I haven't found any role of steroids.
No, I've seen people using it, not that, but I'm not sure about the evidence base. I'll review and let you know in the next session about the steroids in traumatic neuropathy, because I don't want to bluff without knowing that.
Yes.
So
in neuropraxia, you give small dose of for 1 or 2 weeks.
Okay.
That sometimes helps hastens the recovery.
Yes, sir.
That we do use it, yes, even though there is not much evidence.
Yes. So that has covered most of the questions, and we are dots 12:30 on time.